Good afternoon or good morning, depending on where you are today. This is Angie Alanis. I'm with Texas A&M University. I am part of the ITP3 team. We are presenting this webinar today for the folks that we have funded. If you tuned in for our previous webinar, you are familiar with our project that we are funding 15 organizations to develop innovative teen pregnancy prevention programs. As part of our technical assistance and support that we provide to our innovators, we are also hosting a series of webinars. The last webinar that we held was focused on design thinking. Today we are hosting a webinar considering policy, system, and environmental changes in teen pregnancy prevention programming. And we are very fortunate to have members of our own team here today to present to you. We have two presenters, three co-authors of the presentation. All will be available for question and answer after the webinar or after the presentation. So let's get started and let me introduce you to our presenters. Actually, before I introduce, let me tell you a couple of things. We have muted all, so we should not be able to hear you. When we get to the question and answer period, we'll do all of that through the chat box, and we'll give you instructions on how to do that. If you can let us know if there are any issues with audio, just type a note to us privately in the chat box, and we can adjust. Also, prior to getting started, I wanted to let you know, we put this in the chat box, but you will need a sheet of paper for this webinar because you will be doing an exercise as part of this presentation. So, with that being said, let me introduce our speakers today. Dr. Kelly Wilson is an associate professor in the Department of Health and Kinesiology at Texas A&M University. She has considerable experience in managing school and community-based research and practice-related projects, including serving as an evaluator or co-evaluator on teen pregnancy prevention projects, developing professional development for teachers and sexuality educators, and developing curricula for dating violence prevention efforts, as well as directing local efforts to a federally funded evaluation of teen pregnancy prevention evidence-based programs. Oh, that was a mouthful. So we welcome Dr. Wilson as one of the presenters. Also presenting today is Dr. Whitney Garney, who is an assistant professor also in the Department of Health and Kinesiology at Texas A&M University. She has considerable research expertise in community-based research and evaluation, community capacity building, advanced research methodology, including social and inter-organizational network analysis and ecological applications to public health. Our third co-author of this presentation is Dr. Ken McElroy. He is a tenured professor here at the Department of Health Promotion and Community Health Sciences at the Texas A&M School of Public Health here at A&M. Dr. McElroy's previous work in adolescent pregnancy prevention includes 6 projects across the United States. Other substantive areas of research and interest in publications include program evaluation, community interventions, community capacity, and the application of social ecology to health promotion interventions. So I am now going to turn the presentation over to your presenters, Drs. Wilson and Garney.
Thanks, Angie. This is Whitney, and I'll be speaking to you guys first. To start today's webinar, we provided you with a list of objectives. First, we want to review the current levels of intervention in our evidence-based teen pregnancy prevention programs, and then discuss what's missing. And then we'll spend some time discussing a process for how policy systems and environmental interventions can be implemented, and wrap up with an example of how this work is currently being done through a case study. To understand our current teenage pregnancy prevention programs, we looked at the Office of Adolescent Health website to see what setting of the existing evidence-based targets. We found that 25 programs were individually focused, mostly taking the form of sexuality education. 5 were listed as youth development, and 5 more were a mentor relationship-based program. And the final 2 were clinic-based. From this list, we have about 70% of our current programs that are targeting individual level change. And what I mean by individual level change are programs that are focusing mostly on values about abstinence, attitudes about condoms or other contraceptive use, and teach skills needed to reduce risky sexual health behaviors. And while these are certainly important factors, there are many other elements affecting teenage pregnancy rates. If a teenage pregnancy prevention program is to have real effects, we need to combine several effective components that address both the sexual factors affecting behavior in individuals, as well as the non-sexual factors like community poverty and lack of opportunity, relational aspects like family disorganization and peer norms, and then some of the co-occurring behaviors at play like substance abuse or general risk-taking. And this is particularly true of more disadvantaged youth. Here you can see a model that we commonly use in health called the Sociological Model. The idea behind the model is to focus attention on both the individual and their social and physical environment. Within the model, there's 3 different levels, or what I'll refer to as levels of intervention. And these are individual, interpersonal, organizational, community, and policy. The model assumes that by making changes in the social or physical environment, changes will also occur within individuals. From this picture, you can see where the current evidence-based programs are located. The majority are targeting the individual, and then a few are looking at interpersonal relationships and organizational factors like clinical services. There are several implications from targeting individual levels of intervention, the first of which is blaming the individual. These type of programs assume that individuals are responsible for controlling all of the influences on their health, including their environment. Oftentimes we focus on individuals because while we note that there are other levels of influence present, they're simply out of our control or too difficult to address. Another implication of individual level interventions are that they require a lot of resources. When we're looking at sex education in school, we need funds to obtain the materials and pay a teacher, and then continue that funding over time. Therefore, resources must be continually put into these type of programs for them to be sustained. These type of interventions also focus primarily on short-term outcomes. We saw this in the recent Office of Adolescent Health theme issue in the American Journal of Public Health, which focused on replications of evidence-based programs. Most of these programs only looked at outcomes related to knowledge and skills gained, behavioral intention, or self-efficacy. We don't have long-term tracking to know how actual sexual behaviors were affected over time or if teenage pregnancies were actually decreased.
So many of us have probably all been challenged to consider a different frame or point of view when defining a problem. However, in program development, we may not have been asked to use a different lens to seek solutions to that problem. In the next couple of minutes, we are going to walk through a brief activity and encourage you to try using a different perspective when thinking about designing your ideal program. So now is when you can grab your sheet of scrap paper, and I will give you a couple of seconds to pull up your piece of paper and get it in your hands. It can be scrap paper. And I'm going to ask you to tear a 1-inch hole in the center of the paper. Here's an easy way of how you can do that. First, fold the paper in half once, and then once in half again the other way. Now I want you to tear a 1/2-inch piece off the corner that contains no edges of the paper. And now unfold the paper, and you have a sheet of paper with a hole in the middle. So I'm going to give you guys all a couple of seconds again to make sure that you have a sheet of paper with a hole in the center of it. Okay, assuming that you have the paper in front of you, I want you to look around your desk or wherever you're sitting, and I want you to find a specific object and look at it through the frame with your arms stretched out at arm's length. So you're going to be holding that paper with the circle in the center of it stretched out at arm's length, and you are looking at one object. And now I'm going to ask you a couple of questions, and you'll just be answering to yourself. What do you see within this frame? What questions could you answer with the information available to you through your frame? What actions could you take to influence the object or the processes that you currently see? Okay, so those were the questions with the paper stretched out at arm's length. Now I want you to bring the paper up and hold it halfway towards your eye while keeping the same object centered in the hole. And I'm going to ask you another series of questions. What do you see within this frame? What questions could you answer with the information available to you through your frame? And what actions could you take to influence the object or the processes that you currently see? And we're going to do this one last time. Now bring the hole as close as you can to your eye while keeping the object centered in the hole. What do you see within this frame? What questions could you answer with the information available to you through your frame? And what actions could you take to influence the object or the processes that you currently see? The object that you viewed through your hole remained the same during the 3 different inspections. I asked the same questions within each inspection. Did your responses to the questions change? Why did your answers change? Which do you think was the best perspective? Which one did you prefer? Depending on the person who is looking through the frame and the goals of the project really depends on how you respond. We believe that framing in teen pregnancy prevention is partly determined by the capacities of its current health programs and the constructs developers choose to emphasize. Framing offers key insights into understanding the nature of political debate by providing an explanation of both structure and agency in the policy process. By following best practices, framing researchers can usefully interpret the forces that shape policy and strengthen the body of existing scholarship. Framing, as both theory and method, has proven to generate considerable insight into the nature of policy debates in a variety of disciplines. Now, take a look at this first frame. What do you see? Take a few seconds to describe what you see in the dialog box, please. So if you could send us some responses as to what you currently see in this circle frame that is on the slide in front of you. And I'm going to give you guys a couple of minutes to provide responses in your box. Okay. Great, we're getting a couple of responses from people, so I like the engagement in the webinar. And I'm going to give you guys a couple more seconds. We hope that the previous activity that you just participated in with the frames has opened your willingness to consider different perspectives when seeking solutions. In adolescent health programming, we need to be objective about what our own views and paradigms are. So now we're going to expand. There were several of you that identified a blue line, a map, and different things related to it looking like a coastline, for example. So here is a second view. What do you see now? Again, respond in the dialog box as to what you see. And we still have some responses in, so go ahead and contribute. All right. We also hope that you have a willingness to realize that the way that we view something might not necessarily match the way others view it, or might not be the best way to view it. Thanks to those of you who are responding.
I just saw someone recognize that we aren't looking at what they thought that it was in the first shot, but now they know we clearly have the border of the U.S., the South, and specifically someone sees Texas. There is also some data in the frame, specifically something about 84%. And now, here is a clear frame of what we are looking at. This happened to be a frame of one of the national campaign's polling data resources. This was from their Survey Says story, and this image shows the vast majority of the American public has a clear message: don't mess with success. Support is widespread across racial, ethnic, political, and regional lines, as well as among all ages and education levels. From the first frame, I doubt that many of us would have known that we were looking at the results of polling data. Now that we've really thought about our frame, or the lens in which we view things, Whitney's going to pick back up with the discussion about the ecological levels of intervention.
So now that we've broadened our vision about what's actually needed in teen pregnancy prevention by trying to reframe the health issue, we can review the primary purpose of today's webinar, which are policy, systems, and environmental changes, or what I'll refer to as PSV interventions. First, it's important to note that PSV interventions are inherently ecologically based. That is, they address larger levels of influence within organizations, communities, and institutional structures. It's also important to note that the term PSV is a frequently used buzzword among funding agencies right now. But the idea behind PSV change isn't new. The article that was written about the sociological model was published in 1988, which was 28 years ago, and other ecological discussions have even predated that. However, by coining this new term PSV, we have now renewed our interest. So what are PSV changes? First, we have policy, and these can be what we call big P policies that result in laws or regulations, or they can be little p policies that are rules or ordinances within organizations. One example of a potential policy change would be for within teen pregnancy prevention is within foster care systems. What if organizations had a policy to send youth to a youth-friendly healthcare provider during their intake process, and during that visit they receive contraceptive counseling? This would be a little p policy enacted within an organization. Next, we have systems. And systems are a lot more difficult to understand because they can mean a lot of different things, and they can be very big or very small. At the most basic level, a system change is something that impacts a set of things. The set of things or system can be a group of people, an organization, molecules, policy, an environment, and so on. Systems are simply defined by the boundaries that you place on them. One example of a systems change in teen pregnancy prevention is when a health clinic adopts a youth-friendly service model. The model of care requires that providers be trained so they change their interactions with patients, but it also influences how the patient experiences the intake process when arriving, and influences the way the clinic is advertised and how the public perceives it. Therefore, by adopting this model, an entire system of elements was affected. One useful resource for learning more about systems is the book that's listed on this slide, Systems Thinking by Donatella Meadows, and it's a really easy way to get a grasp on what systems are and how you can begin changing them. And lastly, we have environmental change, which I think is the easiest strategy to understand, but one of the hardest to implement. Environmental changes are seen when we make modifications to the physical environment. We see these very frequently in physical activity projects when people build playgrounds, create bike paths, or add lights to sidewalks, and so on. In the teenage pregnancy prevention world, an environmental change could be when a school district decides to build a clinic so that students can have increased access to care. So to summarize, what are the big differences between interventions that target individual level change versus those that target PSV change? Well, obviously the first factor related to individual change is that the intervention focuses on a person. So increasing knowledge, skills, changing an attitude, or building self-efficacy, basically the stuff in a person's head. These interventions also occur at one point in time. Whether it's a one-session program or a 6-week class, the individual participates and then leaves the experience. If there are follow-up encounters, these still occur at some point relatively close to the start of the program, not 10 years down the road. Because they occur at one point in time, they focus primarily on short-term behavior. And yes, while we hope that increasing a person's knowledge about STD risk will make them magically start using condoms, which in turn reduces their chance of participating in a teenage pregnancy, we aren't actually measuring the rate of pregnancy among the population. To be able to detect a change in pregnancy rates resulting from an education intervention, we would need thousands of participants because the rate of pregnancy is actually very small within the population. And lastly, there's challenges in sustainability because these interventions require continued resources. Whether it's money, staff, or location, someone has to assume responsibility for the program long term, and that someone is going to have to commit resources to it. So why are PSV changes better? While they certainly have benefits, you're probably skeptical about how to actually accomplish them because while they're great in theory, they're difficult to carry out. And we'll talk more about that next. One of the main benefits to PSV changes is that they affect populations or groups of people, so they have a larger reach. We aren't having individual interactions. We're creating a structure or guide that impacts individuals indirectly, like creating a policy. In addition, you create a PSV change, they're more likely to persist over time because they're more difficult to remove. If we institute a teenage pregnancy prevention education course in middle school, it can be removed very easily after a parent complains or funds get cut. However, if we build a clinic, that's pretty hard to get rid of. If we create a policy that an organization embeds within their procedures, over time it's going to become routinized and people won't start thinking twice about it because it's now normal practice. And this leads to the last element. PSV changes, like individuals, are embedded within larger systems, like we saw within the sociological model. Therefore, the PSV change affects and is affected by the individual, which can allow it to adapt over time.
Thank you, Whitney. As we've talked to individuals in the field, the question has been asked, should policy, system, and environmental approaches replace individual-level programs? You are about to see a short video developed by the National Education Association related to educational reform. It describes a student's chances for success. It describes a student's chances for success should not depend on living in the right zip code, winning a charter lottery, or affording private school. Let's take a look.
My name is Bill. My name is Michael. We were born on March 28th. We were born in this city. We grew up in this zip code. When I was 3, I went to a great preschool. At 3rd grade, my favorite spot in the world was a school library. When I was 3, there was no preschool in my neighborhood. Once I started school, it was hard, and I kept my head down so the teacher wouldn't call on me to read aloud. When I was in 4th grade, I was excited to be in the band. We played at the gym, the same place all the families packed into the science fair. When I was in 4th grade, school felt boring, but music was fun until it was cut. When I was in middle school, my math teacher started our computer club. We designed video games, and I dreamed of bigger things. When I was 12, Miss Johnston was my math teacher. I would stay after school for her help, but while she was a great social studies teacher last year, it was hard for her to explain math in a way I understood. Now, I'm 17. At my senior year, I'm taking AP classes, and I'm about to graduate. Mr. Crawford, my guidance counselor, helped me apply to 4 different schools, and also for scholarships. Now I'm 17. I'm so far behind, and I feel lost. The college fair was set up in the gym, but I walked right by. But what if we had just changed a few things? So I had classes in art and music, or preschool when I was 3, or a math teacher who loved math and could help me understand. Or now if I had a guidance counselor to help me find every opportunity. And what if we did this and a million other good ideas like them? Not just for me, but for my friends, for everyone like me.
perspective that we just saw. According to the National Education Association, it's that every child deserves access to a system of publicly funded, equitable, and democratically controlled public schools. When we shortchange some students, we shortchange our nation as a whole. This story started with a very individual perspective because we were hearing the stories of Dylan and Michael. However, as we started hearing more about educational reform, what are some system changes that you heard recommended? Please take a minute to type these into the chat box. All right, we have responses coming in. Got universal school or preschool, music and art and music in school, access to rigorous course content. There's still some responses coming in. One just popped in about guidance counselor access. Okay, and to re-summarize that, we are seeing things like provide programs in arts and computers, training for all the teachers and guidance counselors, and the response about access to preschool in all communities. Now, if you were to recommend changes for teen pregnancy prevention reform, would you focus at the individual level on Dylan and Michael? Or would you focus on ideas like access to professional development and training for teen pregnancy prevention educators, and ensuring training to build a population of youth-friendly providers? Would you recommend access to youth-friendly healthcare providers that operate during hours that youth and adolescents would receive care? As we ask the question, should policy, system, and environmental approaches replace individual-level programs? And our response is no, not in all cases. But it is important to think about the problems and make sure we are looking at different perspectives and thinking about ways to enhance sustainable change.
So how do we create a PSE intervention? Like I said previously, they're really great in theory, but they can be difficult to carry out because they require a lot of time, people, and support. Over the past few years, I've been working on a nationwide project to increase access to healthy food and beverages, physical activity, and smoke-free environments using PSV Changes. And let me tell you, the project has not been without its challenges. First of which, we don't have a good guide or description about how to get these things done. People are usually misinformed about what a PSV change is, and even while they might know what it is in definition, they'll revert back to education or promotion when facing a barrier. So while the research is still relatively small, we're starting to get an idea of what PSV change processes can look like. The model on this slide was adapted from an evaluation article in which communities implemented cardiovascular disease and stroke prevention PSV changes. The evaluator tracked steps in which communities implemented the PSV changes and then conducted a comparison to look at what the processes were in different communities. And this is an example of what they came up with that I've adapted to teenage pregnancy prevention. Essentially, there's two big parts. First, we have the typical planning and implementation like we see in other interventions, but second, we have an emphasis on advocacy, or gaining broader community support for the project. Because advocacy is essential to getting the decision makers to see the need of the PSV change, it is critical to start with community mobilization. Building stakeholder involvement, whether that's partnering with a coalition, school, church, or healthcare provider, it's important to just have people. And the second step would be building community capacity for that change. So providing training, technical assistance, building coalitions or networks, creating structures for dialogue. It's important to build the community's capacity for change rather than just implementing a new project cold turkey. As capacity is built, a PSV change can start to occur. And it could occur at one point in time by passing a policy, but that's seldom that simple. Once a policy is passed, you have to promote the change, identify people to enforce it, and figure out methods of tracking. At the same time, most people who do policy work don't get a policy win the first time. It can take years depending on what the topic and level of policy you're working towards, so it's important to not get discouraged over time. I work with the American Heart Association frequently, and they're a great example of persistence. If you ask any of their advocates, they'll tell you that they lose more than they win. But when they make a win, it's big, and because of that, it was worth it. Then lastly, we have community outcomes. And these are way to the far right because they take a long time to get to. Funders don't necessarily like PSV changes because they don't have immediate effects. I can't tell you what the teenage pregnancy birth rate is going to decrease 1 year after implementing a PSV change. They take years and years to show effects. We saw this with tobacco, and while we have good data now, it took a long time to measure. At this point in time, there's measurement options like system dynamics that we can conduct simulations to estimate what the effects are going to be of an intervention, but these are still just guesses. So now that you've seen the big picture or framework, we can look at the step-by-step process. First in terms of planning and implementing, and then second in terms of advocacy, because those are the two larger parts. And it's important to note that these two components are not linear and they don't occur sequentially. They're usually happening at the same time, but for the purpose of organization, we've listed them. So step one is to engage your stakeholders and start identifying an issue. Bring together a diverse and wide group of people to the table initially and try to get people interested. Then narrow it down to a key group later to assist in implementation. But first, it's important to get the people there. And then decide what you want to address. There are a lot of different risk factors associated with teenage pregnancy, so talk to the local people and determine which determinants are the most influential to your location. Once you have people engaged, use data, local if it's available, to figure out what's influencing your issue. Are there a lack of youth-friendly service providers for teens to go to? Or is it that there's no way for them to pay for contraceptives if they can get there? Do you have a special population that has considerations like youth that are incarcerated? One helpful way to organize these ideas and thoughts are through a logic model or planning device. Map out visually what the influences are in your problem and then work backwards to figure out what activities are needed to address them. Next, as a group, pick your point of intervention that's most likely to have the biggest impact. You can't address everything, and while you may identify several issues, choose one or two to tackle first. This will help you prioritize. It's also important to pick issues that are feasible to address. You should dream big, but keep in mind what resources you have. At this point, it's helpful to create an action plan and start to create a working group. Keep the larger stakeholder group engaged, but choose a group of key community or implementation partners who have access to resources or decision makers, and then start to leverage those people's ties to get access to other players that you need at the table. Do you need a gatekeeper to a school or the support of a city council member? Leveraging those network ties will cut down on your work and keep people engaged. If you don't already have funding, this would be the time to start figuring that out and where it can come from. Everything requires money these days. We have to pay for staff, supplies, space, and a million other things. And there's a lot of different opportunities. While we all know that governmental funding is scarce, we often forget about other options like foundations, state contracts, fundraising, or even organizational funds who are perhaps influenced by negative adolescent health outcomes. Throughout these processes, you're creating a structure to guide your PSV intervention, so you're already starting to build capacity. Those partners and relationships that you brought together, they're increasing access to resources and information, and the needs assessment that you performed ensures that local needs are addressed. Consider creating forums for discussion and places for dialogue, as well as other things. In addition, training your project team in skills also builds capacity. So if you're creating a coalition, you can train your staff or volunteers on facilitation and project management activities, and therefore you're building their skills as you go. Capacity is not one single thing. It's a lot of connected pieces that result in communities being ready to address an issue. And lastly, while you're planning, start to talk about sustainability. Hopefully, it's easy to identify what your ideal situation is. An organization creating procedures to carry out a new little p policy, or maybe ensuring providers have the skills to continue assisting youth, and then their EMRs also have a method of accountability. It's best to plan for the worst and best case scenario. What if your policy is adopted but then never enforced? How can you promote it and help assign people to oversee implementation and accountability? Considering these things early allows you to figure out what to do and how to be prepared. The second part of the process is something we as health professionals probably struggle with. Frequently, if we work with governmental grants, we're told to stay away from advocacy, and we see it as a big no. However, there's a lot of different ways to define advocacy that we don't always consider. We don't have to go to a legislator and push for a bill to be passed that changes statewide policy related to reimbursements for contraceptive counseling. We could build support through coalitions, and then the other members could make the ask. We could also focus on little p policy and advocate with organizations or institutions to make systems changes. Media can be a big help. Currently, we have so many options available that we don't have to go to the local news channel and ask them to cover our work anymore. We can promote through social media, listservs, websites, and many other things. But gaining publicity will help build that community support. If you're focusing on policy, draft a policy and share it to get feedback. Make sure it covers everything you consider important, but what other people think too. Engage people in the development so that they feel like they have a stake in the process. And begin to contact decision makers. Chances are this is going to take a while. Between schedules and roadblocks, or maybe people just not liking your idea, this will probably be the most volatile part of advocacy. The stakeholder support will speak volumes for your cause, whether it's organizational or community-wide, but be prepared for setbacks and don't become discouraged. And lastly, attend or host meetings that could continue to gain support and momentum that promote your PSV change. These can be both before and after the PSV change occurs, because once it's in place, you must promote it. Lastly, like all interventions, PSV changes have a lot of considerations. Contextual factors are really key to a success, along with community engagement, because if the political or economic environment is negative, people will be much less likely to focus on the issue. There could simply be things that they're just more important to them at that particular point in time. I'm sure we all have stories of how we worked hard to engage a superintendent or another gatekeeper, and then they were mysteriously fired or resigned suddenly. These types of things happen because it's the real world. But being prepared and having a plan B will be the difference between success and failure. I know I mentioned partner engagement a million times, but if you don't have it, PSV changes are impractical and inefficient. If you go to a CEO of an organization and get their support, but you don't have support of the line staff to implement the policy, it won't succeed. And lastly, timeline and resources are essential. PSV changes take time. They don't happen overnight and they can take years, so be prepared. But there's hope because real people and real organizations have done this and are doing these things every day. Kelly's going to talk to you about a few of those success stories now.
All right, and before we go into our case study, let's take a quick look at PSV again. Within your context of adolescent health, adolescent pregnancy prevention, and teen pregnancy prevention, can you think of some examples of policy, system, or environmental changes that would enhance and advance programs serving your target population? On your scrap piece of paper, yes, even with a hole in it, go ahead and write down what you believe is the ideal setting for teen pregnancy prevention programming. Now, within that setting, identify one policy change, one system change, and one environmental change that you can see in your frame or envision happening. And I'm going to give you about 1 minute to write this down on your piece of paper right now. Okay, and I'm going to give you about 10 more seconds to wrap up your thoughts on your own sheet of paper. And I have a couple of examples for you. So if you happen to choose the school setting and you focused on policy change, one thing that you may have written down is that a school district incorporated a sexuality education resolution that requires trained and qualified teachers to deliver the sexuality education programs. From the systems perspective, you may have written down that all teachers are rewarded for participating in professional development in the area of skill development to promote adolescent health and teen pregnancy prevention. And then finally, an environmental change might be small health clinic events being offered and students meet and interact with youth-friendly health-serving professionals, and healthcare providers are available to interact with students. And now let's take a look at the healthcare setting. So a policy change within the healthcare setting might be that policies are adopted to allow contraception, including LARC methods, be more accessible and accessible by young people. A systems change is the development of a referral system to help young people access youth-friendly services to further promote healthy sexuality. And then finally, an environmental change might be on-site services that enhance youth and community access to contraception and LARC methods. What's important to recognize is that the process is not necessarily linear. Policy does not always lead to environmental change, or environmental change does not always lead to policy changes. So now we're going to look at some specific examples. We've selected to look at long-acting reversible contraception programs, or LARCs, as an example, because many of them have been taken on at the community, state, and national level by a variety of individuals, including health educators and healthcare professionals, with the goal of lowering unintended pregnancy rates. Through many of the established programs that have shown an effectiveness in decreasing unintended pregnancies, we can document the change and identify policy, systems, and environmental structures that support the success of these programs, resulting in decreased unintended pregnancy and a decrease in abortions. Specifically, we are going to look at the Contraceptive Choice Project, which is out of St. Louis, Missouri. And actually, I am going to go back one slide and identify these other studies that have been shown effective. First, there's been an initiative by the American Congress of Obstetricians and Gynecologists and the Colorado Family Planning Initiative. So the American Congress of Obstetricians and Gynecologists would be taking a look at the national spectrum. Colorado Family Planning Initiative was actually a statewide perspective, and then this Contraceptive Choice Project that we are now looking at was a local project in St. Louis. Part of the reason why we selected to use the Contraceptive Choice Project and their Pathways to Choice program in St. Louis as our case study was for several reasons. Number one, the website is easily accessible and has resources that you can access if you want additional information. All you have to do is Google the Contraceptive Choice Project and you easily find their website. There is extensive peer-reviewed literature on their website ranging from 2009 to 2015. One thing that you may notice on the bottom left-hand corner of this slide is a link to their publications page, so you can actually access a majority of their peer-reviewed publications on this project. And a final reason for choosing it is we will be able to walk you through some of the PSV changes that make this an effective systems approach program. We're going to take a quick look at the Pathway to Choice project, which was one component of the Contraceptive Choice Project, and this will be through a video, so I'm going to connect to that video right now.
Women have many paths available to them. How far to pursue an education, what career to choose, how to save or spend money, whether or not to marry. But an unplanned pregnancy can cut off those pathways. Unintended daughters are less likely to complete their education and tend to end up or stay in poverty. Women may have to put their careers on hold. Families suffer financially, and unplanned babies are more likely to have low birth weight and other health issues that can affect them their whole lives. Unintended pregnancy has national consequences. Half of all pregnancies in the United States are unplanned. That's 3 million unplanned pregnancies a year. And U.S. taxpayers currently pay $11 billion annually to cover unplanned births. But not all unplanned pregnancies are followed by births. More than 40% end in abortion. That equals 1.2 million abortions in the United States every year. Why do we have this problem when birth control is available? Some women don't have health insurance or have plans that won't cover birth control. Some must weigh the monthly expense against college textbooks or even against the electric bill. Other women don't follow the rigid schedules required by the pill, patch, and ring. In the real world, these methods have a 9% failure rate, and for women under 21, the risk doubles. If they all have a shared goal of reducing unplanned pregnancy and abortion, it's time to look at what really works. Long-acting reversible contraception, otherwise known as LARC, is safe, easy to use, and highly effective. LARC methods include IUDs and subdermal implants. Because they don't require anything of the user, such as taking a pill at the same time every day, LARC methods have an extremely low failure rate, less than 1% of users. In real-world tests, LARC methods were 20 times more effective than the pill, patch, and ring, but fewer than 10% of American women actually use them. Why is that? While some women can't afford the initial cost, most women simply don't know about LARC methods. Often, healthcare providers just offer the pill, which cuts off a woman's options. She can't take a path if she doesn't know it's there. Things could be different if more women were aware of LARC methods. The Contraceptive Choice Project in St. Louis provided 9,256 female participants with education and access to all birth control methods at no cost. Without knowledge or cost barriers, 75% of choice participants chose LARC methods. And because the majority of women in choice use the most effective methods, their unplanned pregnancy rate was only 35 per 1,000 women. Compare that to the national rate of 52 per 1,000 women. And remember those 1.2 million abortions? That's the same as the national rate of 20 per 1,000 women. Choice participants had an abortion rate of only 6 per 1,000 women. If women nationwide had access to LARC methods, we could potentially prevent up to 1,060,370 unplanned pregnancies and 873,250 abortions every year. If we're serious about reducing unintended pregnancy and abortion, we need to be serious about doing what's been proven to work. Women need education about LARC methods, access to the birth control method that works best for them, and a way to get contraception at an affordable cost. Who knows what can happen when those pathways to education, work, and financial stability stay open? The possibilities are endless. You can help women stay on the path they've chosen. Please, pass this video on.
All right, so that was an overview of a program that has been accepted in the community with LARC uptake by community members and stakeholders who were target populations for this particular project. What have we seen so these programs are successful at the systems level? If you look at advocacy and policy, some of the things that have occurred related to LARC programs is the 618 initiative, which is a Centers for Disease Control and Prevention initiative where they partner with healthcare purchasers, payers, and providers to improve health and control healthcare costs. So advocating to this group is very important for LARC utilization. Also, looking at state Medicaid payment strategies, including policy descriptions and implementation approaches, is very important to consider LARC uptake. This idea of advocacy and policy examples has actually been used in 14 different states to optimize LARC utilization. Some systems level changes or some systems change examples included LARC clinical training opportunities. So this is the hands-on clinical training opportunities for LARC methods, including information about trainings for the copper IUD, LNG IUS, and contraceptive implant, and then expanding LARC training for healthcare providers, which focuses on adolescents and adolescents' use of long-acting reversible contraception. And then finally, an environmental change that occurred within this program is building relationships with family planning colleagues and organizations. Specifically, with Pathway to Choice, there's also the Contraceptive Choice Center, known as C3, and it's a clinic that provides high-quality family planning services for teens and women. Services provided include birth control counseling methods, well women exams, STI testing and treatment, and emergency contraception and pregnancy testing. So one of the things that I want to mention again is what I said earlier when we were looking within the specific setting, is that this process is not always linear and it doesn't always happen in these 3 steps. And so using that as a case study, we are now going to wrap up the webinar, and we want to conclude by saying an effective policy, system, and environmental approach should seek to reach populations and uncover strategies that impact sustainable programs. Efforts may accelerate the adoption of or implementation of effective interventions by effectively integrating approaches into existing infrastructures. Such approaches often include advocates, decision and policymakers. Therefore, we need to be able to identify gaps and differences in our current programming in teen pregnancy prevention and consider a systems approach and if it will help to impact the rates of unplanned pregnancy. Policy, systems, and environmental change approaches seek to go beyond programming and into the systems that create the structures in which we work, live, and play. These approaches often work hand in hand where, for example, an environmental change may be furthered by a policy or a system change. Similarly, a policy could be put in place that results in additional environmental changes. Again, this process is not linear, but a direction that we may want to consider in teen pregnancy prevention. So we are finished with our presentation, and we are going to open the floor for questions, and we will utilize the chat box for those questions. And so we'll give you a couple of minutes to respond and type in any questions into the chat box. I will note that we did see the question from James come in earlier, and we will be addressing that one specifically. And I think right now that's all that the team has. But if you will take a couple of minutes to type in any questions that you have for myself, this is Kelly talking, Whitney, or Ken McElroy is also in the room.
Hi, this is Angie Alaniz, part of the ITP3 team. The first question is actually asking if these slides will be available. Yes, they will be put on our website, which is itp3.org. They will be made available probably by the end of the week next week.
And the webinar will be available as well.
Yes,
the actual recording of the webinar. And you guys can keep typing questions, but I'll read the question that we got midway through the webinar. And the question was, are you saying that you have identified these, and I think these refer to the PSV approaches, as best practices, or are these the type of programs you will be looking for future applications for funding? And so we definitely want to recognize the advances that the field of teen pregnancy has made in recognizing a combination of evidence-based programs, promising programs, and even some practice-informed programs, and making sure that they have the ability to be tested. As far as our applications for future funding, we are not limited to, but we are particularly interested in proposals that address the design of interventions that incorporate ecological or systems approaches. So we are not saying that they are best, but we are saying that they are a level of program that is missing in the field. When Whitney opened up with the summary of the programs that are on the OAH evidence-based list, they were very much focused on the individual. So moving out to the systems approach is definitely something that we would like to see within the field of teen pregnancy prevention and adolescent pregnancy prevention.
So one question that we have is, how do policy systems or environmental changes help decrease health disparities? And I think Ken is going to talk about that one.
Well, I think in part it depends upon what kind of policy we're talking about. It's entirely possible that some policies will actually increase disparities, while others certainly should decrease it. The advantage of PSE kinds of approaches is that we're talking about changes in the physical and social environment that should affect everyone involved. And so since it will affect everyone involved, certain groups may actually benefit more than others because when you have a higher prevalence rate of a specific kind of problem. We can also develop policies that really benefit the most disadvantaged. And if you want to increase disparities, I think that's the kind of policy that one would want to develop, is those policies that disproportionately advantage, as John Rawls would say, the most disadvantaged.
So we have another question that's come up from a viewer, and it is about how you ensure quality within policy systems or environmental changes, with a specific example about social workers who have a policy in place that they're required to talk to youth in care about reproductive health, and that they're provided training to do so. But what if they're still not doing it well? How do you incentivize quality implementation? So this example, I think, occurs at the interpersonal level, where we're really talking about relationships between social workers and then the youth in the system. And so I think by creating the policy, how it's structured is very important. Is the organization implementing it in a way that it's enforceable and that it holds people accountable? Observations of social worker visits could be one way to ensure fidelity in that situation. So I think it's probably a case-by-case situation. Anyone else have something to add?
And I'll add, just thinking about the characteristics of an individual kind of program or more of a PSE change kind of program. A lot of times when you look at the individually based programs, you'll find that they only occur one time. They're focused on behavior change. They're focused at the individual level, and they're not part of an ongoing plan. But the policy, systems, and environmental change actually encourages that you look at change over time and have this change as part of an ongoing plan. So with the social workers, I would really tie that to their professional development and opportunities for training and ensuring that their facilitation skills are looked at as part of the ongoing plan and ensuring that they are improving in the way that they are providing services to youth, and if they have weaknesses, that there is a growth plan for them and actually have a system to improve the quality implementation and track it over time to ensure that it's ongoing.
one thing you might also consider is the use of incentives. Monitoring the performance of social workers is a reasonable thing to do. We do it anyway. We do it through case records and other sort of approaches. But providing incentives to help develop support within the service provider units among social workers may also be an effective strategy, depending upon why they're not doing it. If there's a deficit in performance among social workers, you might want to ask the question, why is that happening? And one of the things that we frequently find is that they're so stressed for time that many times the things that they consider less important are less likely to receive emphasis. And so identifying what the barriers are to actually implementing the policy is a very important strategy.
Hi, this is Angie again. I just wanted to thank everybody for dialing in today for this webinar. I think that we got fantastic information from our team. We will be sending out an email to all of you later this afternoon with a survey. We appreciate you participating in the survey to give us some feedback on this webinar and provide us with any ideas you have for future webinar topics. We will be scheduling another webinar around communication strategies in early January. So we will be disseminating that through our list. If you know anybody that would like to be added to our distribution list for webinars, please send an email to our inbox, which is itp3@tamhsc.edu. We are typing that into the chat box right now. Also, if you are participating on this webinar and are wanting to acquire CEUs for CHEST or MCHEST credit, if you'll please take the survey, the information to be able to register for that credit is at the end of the survey. If there are no more questions, we're going to go ahead and wrap up early and give you some time back. Again, thank you so much for your participation, and feel free to contact us anytime with your ideas for future webinars. Thank you.